So, this is Monica Porter, and today we're going to talk about interpartum pain in labor. So, before we start, we're going to talk about what causes the pain during labor. So, different stages of different labor cause different types of pain. So, during the first stage of labor, pain is caused from dilation, effacement, and the stretching of the cervix, distension of the lower part of the uterus, and contractions of the uterus, which may result in uterine ischemia. During the second stage of labor, pain is caused by hypoxia of the contracting uterine muscles, pressure and distension of the vagina and the perineum, which can be described by the patient as burning, splitting, or tearing. Lacerations of soft tissue such as the cervix, vagina, and perineum. And during the third stage, pain may be caused by uterine contractions and cervical dilation from the placenta being expelled. Pressure and pulling of the pelvic structures. Factors that may affect the perception of pain would be cultural beliefs on pain, depending on whether or not it is acceptable and common to communicate your pain and your fears. Fatigue and sleep deprivation can affect a woman's ability to cope with labor. A woman's past experience with pain seem to be more sensitive to pain than those who have no past experiences with pain. Every woman perceives pain differently. Both attention and distraction influence the perception of pain. So next we're going to talk about the care of our client. So the nurse's assessment should include the assessment of pain. Pain cannot always be assessed by the client's facial expressions. It may require questioning and more intensive observation. Anxiety and fear can increase the client's pain perception. Assess beliefs and expectations related to discomfort, pain relief, and birth plans. Assess pain level, quality, frequency, duration, intensity, and location of the pain through verbal and nonverbal cues, and always use an appropriate pain scale of 0 through 10. So for diagnostic testing, pain is more subjective than objective and is always experienced specifically by that individual. Things that can indicate pain would be behavior, such as crying, moaning, screaming, the gesturing, avoidance, or even withdrawal. Some objective measures that may indicate pain would be an increase in blood pressure, tachycardia, hyperventilation, or a high rating on a pain scale. So our primary nursing diagnosis would be labor related to uterine contractions, stretching of cervix or birth canal as evidenced by grimacing, crying, moaning, and alteration in blood pressure. Some interventions for this nursing diagnosis would be to help the client maintain proper positions to increase comfort during labor, evaluate the client's response to the pain relief methods used, assess if the client has attended childbirth classes, and determine childbirth techniques if taught, if any have been. Provide encouragement, positive reinforcement to the family and the client. Provide teaching between uterine contractions. This allows the patient to focus while she is not having contractions. Provide education on non-pharmacological and pharmacological methods for reducing pain. And also assess for signs of hyperventilation, such as lightheadedness, tingling of fingers. We also want to monitor the blood pressure and the heart rate. So next we're going to go down to treatment. So for non-pharmacological treatments of labor during pain would be childbirth preparation classes, which may reduce the need for analgesia. Childbirth preparation methods such as Lamaze, patterned breathing exercises, or the Bradley method. Yoga, meditation, walking, and massage. Changing positions, taking a shower, or even distracting yourself by performing an activity. Hypnosis, aromatherapy, music, imagery, sacral counterpressure, which provides a distraction to the pain by placing pressure in another area of your body, basically distracting your brain from the main pain that is happening. We also could do application of hot or cold compresses. We do TENS therapy, acupuncture, and then, like I said, frequent maternal positions would be best. I also, before we go into pharmacological, we have this chart, which is from our ATI book, which is an appropriate pain relief measures during labor, which is specific to each stage of labor and type of birth, and what type of pharmacological treatment we should go with depending on what is happening. So we're in treatment, and we're going to go to pharmacological. So pharmacological treatments, sedatives in early latent stages of labor may be used to relieve anxiety and induce sleep. Opioid analgesics, usually given during early on active labor, decreases our perception of pain without loss of consciousness. But we have ondansetron and metoclopramide, which help to control nausea and vomiting. These do not relieve pain, but can be used in combination with our pain medication. We have epidural and spinal regional blocks, or analgesia. Epidural and spinal regional analgesia are used as motor blocks and provide rapid pain relief and provide regional anesthesia, but allow the client to still feel the contractions and have the ability to bear down still. We also have regional blocks, which are anesthesia that eliminate pain perception by interrupting the nerve impulses to our brain. And then general anesthesia, which is rarely ever used unless it is complication of delivery or an emergency. Next, we have collaboration. Nurses collaborate with providers to receive prescription orders and to give good report to the physician and a recommendation based on the assessment of your client. This is important because we know our clients, so we know their birthing plan, their birthing methods, what their preferences are from going forward in their labor process. So that is all important to relay over to our provider when they are prescribing or writing orders. Nurses also collaborate with anesthesiologists as far as prepping the client by making sure we have done our vaginal exam and provided education to the client prior to medication administration, as such as an epidural or spinal block. Then we have our client education. So for client education, it is important to have a support person, which has shown to reduce levels of anxiety in the mother. It is also shown that having a support person improves a woman's coping ability and her overall experience of labor. It shortens her labor, and sometimes it can decrease the need for analgesia, and it can also decrease the rate of the need for an operative delivery. Breathing and relaxation techniques. It's also good to drink plenty of fluids. Change positions periodically and use the bathroom every hour. Hot and cool compresses on the neck and shoulders to relieve stress and tension and to just provide some relieving techniques. And also we want to notify our provider or nurses if the pain becomes unbearable and unable to cope, and the mother feels as if she may not be able to follow through with labor without pharmacological help. So then we also have family-centered care. So it's important to allow our father or support member to be present during labor, which is beneficial to the mother, helping decrease her anxiety. Decision-making should be collaborative between the pregnant woman, the healthcare team, and her family. Freedom of movement is encouraged for the pregnant woman. And then open communication. Well, the freedom of movement is encouraged, which is great for being able to spend time with your family while you're still preparing to give birth to your new child. And then open communication with pregnant women and family members about their desires and their beliefs as far as cultural beliefs and preferences to minimize the risk of misunderstandings. And then by doing all of this, we'll be able to have full care of our interpartum mom that is having pain during labor.